Welcome to today's PerfectServe sponsored webinar, Solving the Complexities of Care Team Collaboration. My name is Vivian and I'll be your operator for today's call. We have just a few announcements before we begin. Please direct your attention to your screen as we briefly go through how today's presentation will operate. Please note that you may need to zoom in or out in your browser to see everything. In the center of your screen, you'll see a box containing today's slides. They will advance automatically throughout the presentation. To the right side of the slides is the Q&A box where you can submit a question at any time. Questions will be addressed during the Q&A portion at the end of the presentation. To the left of the slides, you'll see a resource list with a PDF of today's slides and a few other helpful resources, including the webcast help icon if you need any technical assistance. If you're on the phone line but experience any technical difficulties accessing the web portion, please send an email to webinars@perfectserve.net. At this time, all participants are in a listen-only mode. At the conclusion of today's event, we ask that you complete a short survey that will appear on a separate browser window. And now I'd like to turn things over to Kelly Marinovic, the Associate Director of Demand Generation at PerfectServe Incorporated. Please go ahead.
Thanks so much, Vivian, and hello, everyone. Thank you for joining today's presentation, Solving the Complexities of Care Team Collaboration. I'm happy to introduce today's presenter, Julie Mills, the Senior Manager of Sales Support at PerfectServe. Julie has 14 years of nursing and informatics experience, including serving as a captain in the United States Air Force Nurse Corps. In her role at PerfectServe, Julie specializes in evaluating communication complexities, identifying strategic opportunities within an organization, and designing solutions for client success. And with that, I will hand over the presentation to Julie.
Thank you, Kelly. So to get started, today's learning objectives are to define the clinical communications landscape, identify and understand the complexities of clinical communications, and articulate key requirements to solve those complexities. So, in order to adequately solve a problem, it's important that we first understand what the actual problem is. And so Einstein has a saying that if he had an hour to solve a problem, he'd spend 55 minutes thinking about the problem and 5 minutes actually thinking about the solution. And while I'm not going to take quite that long or in that ratio per se, let's first discuss the current landscape and gain understanding of the complexities. Mobile providers work across many different care settings and are part of multiple teams. The primary center of work for the provider is his or her practice, and communication is driven by voice calls, mobile app, and web by and between many different types of clinicians and includes patients. When we combine multiple practice sites covering multiple hospitals, you can see why it's so difficult to coordinate care when communication between all these constituents is so complex. To truly achieve better care coordination and the efficiencies and revenue that result, a communications platform is needed that's sophisticated enough to be able to connect all of these clinicians in multiple care settings. The outpatient arena is expansive and the heart of physician practices, patients, and all of the supporting organizations for those physicians and patients, such as pharmacies and outpatient therapy offices. The communication processes in each of these entities may be vastly different as their needs are different. Take a physician's practice, for example. There are several types of communications taking place. Patients, pharmacies, labs, hospitals, and other community providers are all calling. Each of these communications may need to be handled differently in order to be most efficient. Large practices may institute their own call center as volumes rise and more people are needed to filter and route communications. Labs may have critical results with timed protocols, and hospital staff may be reporting an acute change in patient status, both of which require timely interactions. Internal staff, such as medical assistants and nurses, administrators, medical records, and front office personnel, need to communicate with each other as well as reach their providers when they are not in the office. Many of these communications involve patient care, and it's important those communications be handled in a secured manner. Many practices employ an answering service, which may operate and communicate with providers in a number of ways. Often these interactions are prolonged by the intermediary and may include calls back to the service or manual tracking of messages or a lack of ability to log responsiveness. The number of healthcare system employed groups continues to rise, and the size of medical group practices seems to be increasing as smaller groups merge to share cost and increase profitability. Employed groups are often governed by a corporate entity and may depend on that administration to make decisions related to communication technologies. Lastly, medical group practices may have an affiliation with multiple facilities, often in different healthcare systems, which means different communication protocols or technologies. This creates issues with adoption, as streamlining communications is imperative for operational efficiency in this arena. The post-acute sector shares some of the same realities of both the outpatient and inpatient world. There is a constant need of beds for those transitioning from the acute hospitals, and the requirements of insurance companies or payers for those still in residence. Case management or care coordinators and social work manage a large piece of these vital transitions and often need to communicate with the facility administrators or accepting physicians in a timely manner. Likewise, the discharging provider would often like to give report in real time, but the inability to communicate efficiently impedes this handoff from occurring. The post-acute community is also known to have fewer technology options available. In many cases, providers create processes to not have to call back to these facilities because they're not answered in a timely manner. Many of you have probably seen a call sheet just like this. This is an example of an honest effort on the part of the hospital staff to follow physician contact preferences. You can see the device numbers are visible here for anyone to see or jot down. And on the right, we have special instructions about how each doctor wants to be contacted. The problem with these sheets is that they aren't updated in real time. And eventually, as changes get made, they're harder and harder to follow. I always like to point out a few examples, such as scratched out numbers or handwriting that is difficult or hard to read. Instructions like beep or call myself first, but there's no instruction as to what to do second. Do not call on Wednesday, with no direction on what to do on a Wednesday. Or do not call at home, but there's a home number that's listed. The acute care space is riddled with communication complexities and thus breakdowns. Many of the solutions we see in the market are designed to bridge the communications gap for hospitals, but don't reach outside the four walls into physician practices or systems located on separate campuses. When examining the acute care space, it's imperative to acknowledge the vastness of interactions that occur. Nurses and other care team members, those care team personnel to hundreds or even thousands of providers, one medical staff to the staff of a sister facility, maybe with a higher level of care, and the transfer center in between, as well as the primary care providers in the community. Inside the four walls is only the first step. And while it's a necessary and important one, the continuum of patient care demands that solutions span much further. As healthcare delivery models change along with reimbursement, it's imperative that coordination of care be streamlined and efficient across all of these settings. The effort to keep patients out of the acute space when possible and shortening stays in the hospital when able demands a robust process of outpatient and inpatient communication with both providers and care participants. Instead of focusing on the medical staff of a hospital or who is employed versus independent, providers may look to ACO participants for consults and referrals. This is an actual study of the communications process in a 528-bed hospital, and the nurses in one unit experiencing all of the different ways in order to reach a provider. So we actually sat with the staff and mapped all of the different ways and the different steps that they had to take. And what you can see is that each shape represents a different step, a different handoff, a different transition, and all of these different items introduce risk for communication variability and breakdown. So now that we know the landscape, let's review key components to consider in the communication cycle. First, the initiation of a communication. When examining methods of initiating a call or message, there are many options available. Those patients or practitioners in the community will likely choose a phone, whether it be a mobile, a home, a work, or a hospital phone, to reach out to someone. Nurses and other ancillary members in a facility may have additional options, a VoIP phone, or perhaps a messaging service available via their workstation. The workstations may be at a desk, at a bedside, or on wheels. Additionally, a personal mobile phone may be used to call or text a provider's direct cell. The reality of healthcare today is that there are fragmented technologies, point solutions, if you will, that exist to solve a unique situation, but those solutions aren't comprehensive enough to solve the entire spectrum of clinical communications. This leaves caregivers functioning in a world of disparate systems, many of which may not be updated and current, so there is continued frustration and the continued quest to solve the communications issue. Point solutions have tended to be offered in one of four areas. Nursing communication with vendors such as Volt or Vocera and a myriad of other VoIP vendors, each with their associated middleware, such as Extension and ConnectSol, and the relatively recent need to comply with HIPAA regulation that has spawned countless secure messaging vendors in a rapidly commoditized secure messaging space. And lastly, physician communication, where fewer vendors have attempted to deliver a comprehensive solution. However, it's commonly the most complex and essential. The method of initiating a communication may vary based on a few factors. First, what available technologies exist currently? Many people no longer have home phones or even phone books. In the hospital, there may be a communication solution in place that allows or is a standard for communications. It may be used consistently, but if not found to be comprehensive, often other methods of communications are used. The urgency of the message may drive one to call as opposed to send a message. If immediate feedback or more dialogue is needed in order to determine next steps, calls are preferred. Likewise, many providers can't make themselves immediately available for non-urgent communications, so text messaging is preferred. Convenience is a factor as well. Many find it easier to have a conversation if they're multitasking or perhaps walking on the go and are not able to be tied to the workstation to send the message. Others simply prefer to discuss in real time rather than send a series of messages back and forth. In addition to initiation, there is the process. And in reality, most communications must start with process before ever reaching initiation. So often people aren't sure who to contact, and there's an extensive process that takes place to determine who to reach before ever engaging the technology or the initiation step. I'd like to challenge the standard and allow you to see a world where the pre-work is removed and the process is built into the cycle in a more meaningful or effective manner. This is reality. Lists, notes, Rolodexes, binders, all with outdated information, different acronyms, and differences. Every group on the medical staff and beyond, and every provider in that group has a process and a preference. The expectation is for nurses and care team members to know the process and respect the preference. To a nurse covering 8 patients, each with 4 to 5 providers, it's burdensome to keep up with who is part of what and how. So PerfectServe commissioned a Nielsen survey of 1,000 healthcare members, both inpatient and outpatient providers and care members, administrators, case managers, and more. The results are displayed here and are most likely not surprising to any of you. A few key results I'll touch on. 97% note that the extended care team outside of the 4 walls of the hospital are critical to population health management. 70% are using disparate systems or technologies, and 50% don't know who they need to contact, which is really the heart of communication. The process or pre-work being done is still leading to 50% of us not knowing who we need to reach out to. Additionally, the EMR has not been widely adopted for communications. When looking at workflows, it's important to understand the innate variances. Let's examine nursing assignments. The patient census and acuity is evaluated, and assignments are made. Thus, there's a direct nurse-to-patient assignment. With ancillary departments, respiratory or physical therapy, for instance, there may be more of a unit or department coverage model, even an entire floor or zone. Often, other team members are calling shared pagers or phones to reach the covering therapist without knowing who that person actually is. In care team to care team communications, the key factor is availability. Staff may reach out to a role, say a 4 West charge nurse, and the phone may ring and ring without answer. Obviously, that person is not available at the moment, and there's no intelligence built in, so the caller is forced to wait and try again later. In some solutions, the role doesn't tell you who's actually covering, so you're not sure who isn't answering in order to know who you might reach out to next. This is where real-time updates come into the picture. Imagine you're going into isolation, and you can click a button on your device that lets the caller know you're unavailable and escalates the call to another nurse or therapist. Or perhaps if the 4 West charge nurse doesn't answer the call, it's automatically pulled back and you're redirected to the backup person or phone. Another reality of care team workflows is staffing. Based on your unit or department's census and the needs of the house, you may not have as many personnel as planned. The ability to adjust assignments in real time that are reflected throughout the house is important as well. Physician and advanced practice provider workflows are significantly different than care team processes. When consulting with different provider groups, we find dozens of ways to accommodate the same workflow, thus the need for tremendous flexibility when designing a solution. It's not as simple as being available or not available. Rather, we have to consider many factors. The originating role. Is this a patient, a nurse, or a physician? I may want to ask different questions or receive the communication differently depending on who is reaching out. The location. If I operate in multiple facilities, there may be different workflows and schedules based on which site. Or on a more granular level, if I'm a surgeon and the OR is calling, I might want to receive that more directly than a routine message from a medical surgical unit. Some provider coverage models are determined by choosing patients at the beginning of the shift each day. There's no predictable coverage model, making it difficult to know who to reach out to for your interactions. By integrating the group's patient list, we can route to the covering provider by asking for the patient's name. Critical results versus routine consults at 2 a.m. that could be held in the morning are also a key part in determining communications. So the urgency is vital when thinking about how to handle different matters. The reason, so is this regarding a new admission, which may lead to a different schedule? Or is it about an inpatient, in which case one of 8 rounders might be covering? The date and time are vital when thinking about day processes versus night coverage models. And of course, the schedules are always an integral part to determining who to contact. Many solutions may stop there, and in most cases, there are still considerations that need to be evaluated. This is where status comes in. I'm on call, but I'm in the OR right now. When a nurse reaches out, I can't respond, and the circulating nurse may have my device, but is busy doing counts or tending to needs in the room, so there's no response back to the originator. In many cases, there are subsequent communications sent, as the caller is uncertain of the status of the message. There's also no automatic escalation process to redirect the caller, so they're left being unsure as to the next step in the process. Imagine a world where you're notified that the provider is currently in the OR and asked if your message is urgent or routine. If you say urgent, it can route to a backup provider or perhaps ring the phone. If routine, a message can be left and you don't anticipate a callback in the near future. In addition to workflow considerations, there are varied coverage models that physician groups and practices may adopt. Some providers may cover their own patients, those that they see in the office, for instance, or ones they admitted, and we would refer to that as an each takes own. During daytime hours, care team members know to reach out to that provider. And of course, they may be on vacation or sick, so it's important that there are considerations in the routing. Another common model is to have one person from the entire group cover all calls for the practice. So there's one on-call person that changes each and every day. Finally, there's a patient-centered routing setup that I mentioned earlier where patients are assigned at the beginning of a shift to the currently working group of rounders, and tomorrow there may be a different set of rounders covering a different set of patients. This is common in large hospitalist groups or internal medicine and pediatrics residency programs. Other important models are team coverage, where a physician assistant or nurse practitioner, or other provider are all covering one set of patients. They may need to all get one communication, or one person may field the messages and distribute to the team as appropriate. Unassigned ER call is common and provides coverage for those coming into the emergency room not currently being covered by a specialist, but in need of one. These schedules are usually managed by the hospital, not a particular practice, and they're a shared responsibility. They're also the source of many communication breakdowns, as group coverages may change and the hospital doesn't receive the update. Consults and admissions many times have separate coverage models in some practices, so it's important to consider the reason for the communication prior to determining who is covering. Lastly, team alerts are instances where we need to quickly mobilize a group of people for a specific reason. These alerts may be a team that is entirely internal, like a rapid response team or a code blue, or a mix of internal and external, like a code stroke team. Different schedules and departments are included, some responsible for responding and some as FYI members, adding a layer of complexity to the communication. It's imperative that the covering providers acknowledge these communications quickly and that there be a process to notify a backup provider in the event that key personnel don't respond, like the on-call neurologist for the stroke team. Reporting around response times is also an added necessity for these events. The tools currently available are insufficient to address all of the complexities seen in clinical communications. And I'm sure you have all of these things available in your institution today, whether it be a call center or services, the telecom department and the operators, whether there's overhead paging or paper or web directories, Rolodex and lists, or sticky notes and 3-ring binders. All of these fail to address the inherent complexity of clinical communication, which is why we continue to see breakdown and communication failure. Lastly, let's consider the recipient of the communication. I mentioned the availability of the recipient at each moment in time, Because situations in healthcare are ever-changing, the ability to update one's status on the fly is imperative. But it's not enough to say, I'm busy or unavailable. Rather, there has to be elements of managing the expectation of the originator, as well as the ability to dynamically redirect to an entirely new process. As with initiating communications, there are many modes of receiving them. Many providers still carry pagers, whether out of necessity or preference. There are some with standard cell phones that don't have access to mobile applications, while many operate from a smartphone. There are VoIP phones, shared devices, and home desk and office phones. All of these devices drive the delivery of the communication, which may vary based on all of the factors we discussed earlier: the urgency, the reason, location, and role, and so on. Solutions must accommodate these variations in order to bring holistic adoption. HIPAA compliance has become a hot topic over the past several years as we're seeing more incidents related to protected information exposure. As there are a variety of devices being used to receive information, solutions must address those with pagers and SMS text, not just the secure messaging text application. Organizations must look at communications routing through a variety of sources, not just nurses to physicians. The graph on the right is an example of a hospital using PerfectServe and the breakdown of communication devices used to initiate or receive messages. While secure text is encouraged, it's unrealistic to think it's a comprehensive solution. Analytics like this bring a measure of accountability and, more importantly, auditability to the organization. As texting becomes more prevalent, it becomes imperative to see things like read receipts and have record of communications. JCAHO also recently approved the ability to text orders via secure communication tools, but there are additional requirements, such as read receipts and the auditability pieces, that have to be evaluated before policy implementation can occur. The number of secure texting applications has exploded in the market to address this concern, but without addressing the other workflow considerations, they experience significantly low adoption, which leads to abandonment of the tool altogether. With more than 100 vendors in the space currently, many IT organizations are using secure messaging on a temporary basis while seeking more strategic, comprehensive solutions. Solving the complexities that we've discussed requires a robust solution that includes several key areas. Let's discuss them one by one. Clinical communication solutions must be as comprehensive as the communication pathways themselves. Adopting a point solution to address nursing communications isn't adequate when the most complex communications nurses encounter are those to their physician colleagues. The technology must be capable of addressing the needs of a single hospital, a multi-site system, and reach into outpatient practices and care settings. Advanced directory capabilities bring the opportunity to coordinate care based on facilities, groups, or ACOs with the appropriate workflow processes built into each arena. Groups operating in multiple hospitals or care settings must have one standardized way to filter and direct their communications with efficiencies greater than routing calls to an office or an answering service. Most importantly, the ability to generate real-time updates when patients present to the emergency department, are discharged home, or have critical results are essential to timely coordination of care. Imagine your office is securely notified when a patient is discharged from the ED or the hospital, and you have the opportunity to proactively schedule their follow-up appointment. It can happen. Solutions must provide a standardized way to communicate that accounts for present-day technologies. Whether I pick up the phone for an urgent call, send a secure text via my workstation on wheels, or launch the secure application on my hospital provision smartphone, I'm able to access the solution, ensuring that I'm routed appropriately. Gone are the days of referencing binders, Rolodexes, and schedules or Post-it notes taped to the wall or desk. And all that is required is that I access the solution and follow the process. Whether you request by name, role, or specialty, the workflows, schedules, and status are all included. Providers and administrators have real-time access to updates, so reaching the right provider has never been more streamlined. The goal is simple. Remove the variability, remove the handoffs and touchpoints that introduce risk and opportunities of communication breakdown. Initiate the communication in the manner you wish and let the process connect you to the correct covering provider for your clinical situation at every moment in time. The key to making the process work is dynamic, intelligent routing. It takes more than a schedule and a phone list, more than an operator referencing a schedule and a phone list. Solutions require the ability to search in several ways, and regardless of how you search, the incorporation of the required workflow routing. We know that our day-to-day tasks are ever-changing, so the ability to make real-time web or mobile updates to coverages, schedules, or patient assignments is crucial to success. Based on the clinical situation or your availability, messages may need to be held until the morning or until you finish your meeting or procedure. Additionally, how you receive those messages may vary, and it's vital that the technology be as flexible as your needs require. This is a complex hospitalist schedule, and it actually is only a schedule for a week's period of time. There are several facilities that are listed, and each facility has a different coverage team. The list of docs next to the facility name notes which rounders will be covering. The inpatient floor calls will be covered by these rounders according to patient-centered routing, determined by patient doctor to assignments that are established each morning. Each facility has separate rules for ER admission calls. These don't follow patient-centered logic but go to a dedicated doctor according to the schedule. Each facility also may have separate rules based on different geographical areas, such as the CVOU. And these also go directly to the physician that is assigned specifically to that area. All of these rules are divided among multiple shifts throughout the day and night. And at night, the patient-centered logic stops, and a specific doctor is on call for floor calls. Some of the staff filling schedule slots might be physician assistants and not physicians. And there are notes on the schedule about which physicians are on vacation. This diagram shows the workflow process and all of its intricacies. And we established the diagram after a comprehensive consultation with the group and design it based on their ideal practice, reflecting considerations such as facilities, time of day, department, patient, and role. While the process may be complex, this is the experience of the initiator. It's very simple, straightforward, and very elegant. All of these communication-driven workflows, including schedules, work group rules, group and team mobilization requirements, and escalation paths, are designed in our platform. The need for communication occurs for any particular situation and time. PerfectServe will automatically analyze the variables and determine the appropriate routing to the right physician or care team member. This results in real-time, accurate, dynamic communication routing. The need for manually maintained on-call schedules, Rolodexes, and lists is eliminated from the process, and with them the potential for delays and breakdowns in communication that negatively affects patient care. For true care team collaboration to occur, these disparate technologies must consolidate into a solution that can seamlessly deliver all of the pieces. Whether it be a native platform or an integration where all of the pieces are delivered through one technology, the end user experience should be seamless and coordinated. As the market of clinical communications and care team collaboration expands, the solutions in this space will need to more tightly align to provide a more streamlined experience for care team personnel. While each technology in healthcare has their purpose, such as the EHR, the more compatible they become with other systems, the more effective coordination of care will be. Imagine a world where you launch the EMR, review a patient's chart, and want to discuss care with the covering cardiologist that day. Imagine clicking a link for the cardiologist, and it references the provider's group workflow processes, reviews their schedules, and monitors their status to direct you to the correct provider. You simply type your message, the patient's information is pulled from the EMR, and is securely routed to the recipient based on their contact preference in that moment in time. It can happen. Key pieces of routing may come from other systems, like the patient information for a group, or notifying a primary care provider that a patient has been discharged from the emergency department and requires follow-up in 2 days. The ability to deliver these features or this integration of access and messaging is possible due to an open architecture, which allows for information exchange via a flat file, secure FTP, HL7, or a RESTful API. In simpler terms, we can accept the information from other HIT systems, whether it be the EHR or the nurse call system, and route them to the correct provider through that dynamic intelligent routing to reach the right person at that moment in time based on real-time status and delivery preferences. While doing the work to send the message may seem like winning the battle, it's imperative that there's up-to-date message acknowledgement with related loggings and analytics. If I send a message to a nurse regarding a patient request and she never reads the message, what is next? Where does it go, and who follows up? If I send a physician a routine consult, how do I confirm the message was received? What if 24 hours passes and the patient isn't seen? Is there a record of the process? If a code STEMI is called and the interventionalist on call doesn't read the message, is there a human being watching the clock to call again? All of these situations are very real to us, and they happen daily. Solving the complexities of clinical communications doesn't end with sending the message. You have to ensure it's received and acknowledged. The solution must have a notification process designed to meet the clinical situation, customizable to each provider. As a hospitalist, I may receive 100 messages per shift and don't need frequent reminders as I'm checking messages often. A STEMI requires an aggressive notification protocol to ensure timely response. But after several notifications and no acknowledgement, there must be smart escalation or redirection of the message via a backup process. The group designs their backup plan, and in the event a care team member or provider doesn't pick up a message, there's a prescriptive process in place that doesn't require the originator to continue to seek the next step. The ability to audit these notifications and subsequent escalations is key to a risk mitigation strategy. Finally, the solution must have the flexibility to span all of the recipient's preferences. If a physician loves their pager, there shouldn't be a separate process or solution. Rather, the technology must be encompassing enough to address that scenario. In this picture, you can see examples of ways communications may be initiated via hospital systems, clinicians, or providers out in the community, as well as patients. Each of those communications is processed via dynamic intelligent routing and is sent out via the recipient's preference, whether it be call, message, page, or text. Real-time calls provide caller ID anonymity and a backup step should the recipient not answer. Secure messages can be accessed via a mobile application, web, or by calling into the secured inbox with authentication. Messaging sent to pagers and SMS text are screened for PHI, and those fields are filtered automatically. Your page will still include the callback name, number, and reason for the message, but the patient-specific information is removed in order to protect their PHI. As technology continues to grow, new devices become available, and it's imperative that solutions be accommodating of clients' evaluations and choice of mobile device. Here you can see not only an Android and iOS device, but the SpectraLink Pivot, Cisco 7925 VoIP phone, the Motorola MC40 Zebra, and the Ascom Myco device. Several of these are emerging nurse-provisioned smartphone devices, purpose-built with technologies needed in the bedside care team space. As these devices become increasingly popular, it's reasonable that hospitals may want to try more than one. So it's necessary that solutions support any option, as the investment may be substantial. Again, flexibility and customization. In summary, healthcare communications provide great challenges, but the right solution can lead to tremendous benefits for every care team member as well as the organization. The solution must be comprehensive, providing standardization and the ability to streamline the communications process. Dynamic intelligent routing is essential to addressing complexities and driving sustained adoption. Integration capabilities can incorporate existing systems to provide a more robust and efficient process. Ensuring messages are acknowledged and having the analytics to reflect the interaction is vital. These criteria will ensure that you are successful in addressing the obstacles in clinical communications and have a correlating improvement in both physician, care team, and patient experience. And at this time, we'll address any questions.
Great. Thanks, Julie. You provided some really great information, and we do have a handful of questions that have come in. For any of you who have not yet submitted your question, please feel free to do so in the question feature on your screen. And with that, I'll get started with the first question here from Dan. What hardware or software is required for PerfectServe?
That's a great question. So PerfectServe is actually a cloud-based hosted solution, so it does not require any specific hardware or software to be implemented or located on-premise. PerfectServe can be accessed easily, either an extension that's set up through the telecom department on any landline phone, via a common or recent web browser, as well as native mobile applications that are available to both iOS and Android devices.
Okay, great. The next question here is from Lindsay. Do you provision specific devices for the nurses to use?
Actually, PerfectServe is what we call device agnostic, and so we can work with any devices. And while we share information about what's most common in the market or what other decisions that have been made and what we hear, we do not actually provision any hardware, but rather we give the organization the ability to choose and trial and have the flexibility to pick amongst what is available in the market currently.
Okay, perfect. Just a few more questions have come in. Next is from Mike. How do you find other systems managing the app on hospital supplied devices?
That's a great question. So with hospital supplied devices, the understanding and the common feature amongst them is that they're shared devices. So if you have nurses that are coming in for their shift, they go in, they pick up these devices, and then they have access to the application. So obviously there is authentication that is required to the applications that are there. But there's also the understanding that there are some security features as PHI can be sent to those applications that they're logging into. So some healthcare systems may choose to replace MDM or medical device management solutions on those devices, and that allows, from an IT perspective, to be able to remotely control the application. So if for some instance a device goes home accidentally with someone, they could remotely lock down the app or even wipe it and remove it from the device. So that's a common choice as well. And then PerfectServe, in and of itself, the mobile application is secured with authentication steps, both with usernames and passwords and PIN requirements. And it does not cache any of the protected health information on the device specifically. So without unique authentication to the mobile application on the device, if someone else were to pick it up, they would not be able to gain access to any of that protected health information.
Okay, great. Just two more, it looks like, have come in from Joan. What does the hospital do if PerfectServe is down?
That's an excellent question, and I think it's a common expectation with other types of HIT systems in the marketplace. There are either planned downtimes or outages or unexpected downtimes or outages. With PerfectServe being that it is kind of the center of all communication processes, and at any moment in time, there is no good time to not be able to communicate, PerfectServe structures the platform in such a way that there are no planned downtimes or no maintenance downtimes, and we also kind of set up in a multi-structured approach to ensure that if one aspect or one communication method is not available, there are always others. So for instance, when PerfectServe deploys in a hospital, you can always access PerfectServe via a phone or a web browser. So there are instances where maybe internet access to the organization is down. You could still pick up the phone, and all of those same rules and processes are going to be in effect, and they can still route those communications appropriately. So that's kind of the front end of it. And then depending on, if you go in by phone, you go in by web, once it reaches our platform, which again is hosted, we have a data center that has redundant setups and structures internally so that the platform actually runs on an A and B side, so that if for some reason the traffic running on the A side experiences some sort of outage or there's a server that goes down, there's a backup process to shift traffic to a backup server or to the other side of the platform. And then lastly, we even have a backup data center to our primary data center so that in case of any sort of perhaps natural disaster, fire or tornado and such, there's a failover site in which PerfectServe could continue communication processing and accounting and reportability on that backup data center.
Okay, great. And we have one final question in the queue right now from George. Does any message content reside on the desktops or mobile phones?
No, and that's a key part of security from our perspective is that when the application is launched, whether you go in through the web browser or you go in through the mobile application, there's a unique authentication to the information. And once that authentication has been done, it is actually pulled in real time from the server. So what is displayed to you is pulled in that moment, so it's up to date and it's accurate. And then when you step off of that, when you sign out or you're auto logged out from the information, all of that information is obviously sent back to the server and is not left resident on any device, whether it be a desktop or a mobile phone.
Okay, great. Well, that appears to wrap it up for questions. If you have any questions after the close of the webinar, definitely feel free to reach out to us at contact@perfectserve.net. And with that, I would just like to thank Julie for an amazing presentation today. Terrific job as always. And to thank our audience for your participation. We would love to have your feedback to ensure we provide the most beneficial information in the future. So please just take one moment to complete our short survey. I wish you all a great afternoon. And with that, I will hand the presentation back over to Vivian.
Thank you. Ladies and gentlemen, this concludes today's conference. Thank you for participating. You may now disconnect. Speakers, please